after the COVID-19 pandemics, a lot of mental disorders is in a rise. And then obsessive compulsive disorder, or what we know as OCD, is also one of the most severe mental disorders. So today we have Johan Mustaqim here with me to discuss about this case.
Yeah.
And later, our principal consultant psychologist, Dr. Edward Chan, he will also join this webinar to provide more insight on how these obsessive compulsive disorders happens and how can we treat it. So today, Johan, I would like to know what kind of disorder is OCD?
All right. Okay, so good afternoon to everyone. Welcome to our webinar. All right, so like Tommy say, today we are talk about the obsessive compulsive disorder and related mental health disorder increase in a COVID-19 pandemic, right? So actually, before I go to OCD, we must understand first is what is all about mental health, because for me OCD they are same with mental health. So actually mental health includes our emotional, psychological and social well-being. So it affects how we think, how we feel and how we act. All right, so it also helps determine how we handle the stress related to others and make a choice. Mental health is important at every stage of life, from childhood and adolescence through the adulthood. All right, so actually over the course of your life, if you experience mental health problems, your thinking, mood and behavior could be affected. So many factors contribute to a mental health problem, including biological factors such as like gene or brain chemistry, life experience such as a trauma or abuse, and a family history of a mental health problem. Okay, so when we talk about the obsessive compulsive disorder, OCD, is a common chronic and a long-lasting disorder in which of the person has uncontrollable, requiring thought, which means obsessions, and a behavior that which means as a compulsions that he or she feel the urge to repeat over and over. All right. So obsessive compulsive disorder (OCD) is a disorder in which people have a requiring unrelated thoughts, ideas, and sensations. Okay, that make them feel driven to do something repetitively. The repetitive behaviors such as hand washing, checking on the things or cleaning can significantly interfere with a person's daily activities and the social interaction. So that's the what I know about the OCD. Yeah, that's all to me.
Okay,
All
thanks,
right.
Johan, for sharing your knowledge on
Yeah.
OCD. So, Johan, just now, right, you got mentioned a few symptoms that are related to OCD. But I would like to know more. Other than all the symptoms that you mentioned just now, is there any others example of OCD that you can share with us?
All right. So for the symptom, OCD obsessions. Okay. So for the system, okay, obsessive compulsive disorder usually include both, which mean they are include obsessive and compulsions. All right. So, but it also possible to have only obsession symptom or only compulsive system. Okay. So might be they have a two type of a symptom and just one. Other than that, other than obsession or compulsions. All right. So you may not realize that your obsession and compulsion are excessive or unreasonable, but they take up a great deal of a time and interfere with your daily routine and the social, school or working functioning. Okay, so I just give example for the obsession symptom. Okay, so actually for the OCD obsession are repeated, persistent and underrated through the urge of image that we interceive and cause distress or anxiety. All right. So you might try to ignore them or get rid of them by performing a compulsive behavior or ritual. This obsession typically intrude when you are trying to think of or do other things. All right. So obsessive often have them to them such as like a fear of a contamination audit. Okay, so doubting and having a difficulty tolerating uncertainty or needing things orderly and symmetrical, aggressive or horrific, true about losing control and harming yourself or others. All right. So just as an example of the obsession sign and symptom include fear of being contaminated by touching object others have touched, doubt that you have locked the door or turned off the stove. All right. So intense stress when objects are not orderly or facing a certain way. Okay, that's just a few examples that I can give. All right. So actually, when we go for the completion symptom, all right, OCD completion are repetitive behavior that you feel driven to perform. All right. So this repetitive behavior or mental acts are meant to reduce anxiety related to your obsessions or prevent something bad from happening. All right. So, however, engaging in the completions bring no pleasure and may offer only a temporary relief from anxiety. All right. So you may make up a rules or ritual to follow the to help control your anxiety when you're having the obsession touch. All right. So these compulsion are excessive and often are not realistically. All right. So it related to the problem they are intended to fix. All right. So as a with obsession, compulsion typically have a themes such as like washing and cleaning, checking, counting, other lines, following the strict routine, something like that, right? So the example of the completion sign and the symptom include like hand washing until your skin become raw, all right? Checking door repeatedly to make sure they are locked, all right? Checking the stove repeatedly to make sure if it is off, okay? Counting the certain patterns and something like that, all right? So that is what I can share about the symptom. So for what I shared, that when we talk about OCD, they have a two, obsession and compulsive. So might be individual they might have a both symptom, and might be they just have a obsession or compulsive only. Right.
Okay, thanks, Johan, for all this insightful sharing.
Yeah.
So, I would like to know if we really have OCD, if we suspect we have, what can we do?
All right. So for me, if you realize that you have a OCD, you can refer to the to do a therapy, such as like might be you can come to the International Psychology Center, right, to meet Dr. Edward to make a therapy and so on. So actually, when we talk about disorder and something like that, it might be have a therapy that we can do to reduce our OCD and something like to reduce our OCD, right? So you need to meet up with someone who more knowledge about the OCD, such as like counselor, psychiatrist, or therapist, to help you to reduce the OCD. Because for me, when we talk about OCD, you will not easily that you will say you have OCD. All right, they have any step that we as a therapy or counselor will do, such as like diagnose. Okay, we will do a screening or something like that to make sure that you really have a you really have an OCD and so on. All right. So when you meet someone who have do a screening and diagnose you have OCD, so might be for the next step you will doing a therapy with the therapist or the psychiatry or the counselor lah. All right. So might be it depend on your situation. Might you have to take a medicine or might be you just focus on the therapy to heal. It depends on how the level of your OCD lah, right?
Okay, yeah. So, if we have a OCD, right, like what you say, we need to seek help from a
Yeah,
therapist. We can
yeah,
go to psychologist center, book an
yeah,
appointment with
right.
psychologist. what kind of things, what kind of option is available to help us to reduce all these obsessive thoughts and also the compulsion behavior of keep on repeating to do the same thing. Okay, so Johan, I would like to know, right, what kind of therapy method do you think will be very useful, very effective in treating OCD?
All right. So actually, for OCD, I have a read about the treatment are available for OCD, right? They have any treatment that we can use to treat people who a treatment that are available for the OCD, right? So OCD is typically treated with the medication, so psychotherapy or the combination of the two lah. So through most of the patient with OCD respond to a treatment, some patient continue to experience the symptom, all right? So sometimes people with OCD also have other mental disorders such as anxiety, depression, or body dysphoric disorder lah. So a disorder in which someone mistakenly believe that a part of the body is abnormal. All right. It is important to consider that other disorder when making a decision about the treatment. All right. So such a treatment that we can do is like that I have read about the treatment of the OCD is a toward rapid acting treatment for OCD. All right. So that is the one of the treatment that I know that I have been read during my study is towards rapid acting treatment for OCD. Right, that is such the treatment of for that is my answer. All right, for me.
Okay, thanks, Johan. So, right now, right, currently you say that therapy method and also medicine, both of these method
Yeah,
is useful in treating the OCD issue. Okay, so I would like to know, do you have any experience of treating an OCD patient? How they
all right,
really?
all right. So actually, for my background, okay, I just want to tell all. Okay, so my background, my degree is a psychology, and my master is a counseling, right? So as a my experience, I'm more to a counseling, right? I I have a experience as a counselor. All right. So in a psychology, there are many of type. They have a psychiatrist, they have a therapist, they have a counselor, as such as like that, right? So based on my experience, that yes, I have met a client, which is my student actually. He have a OCD, all right. So when at the one moment he always told me that he have a OCD, right? So me as a counselor, the first step that I do is make a consultations, make a consultation using a scent therapy or play therapy, because I also have a certificate for the scent therapy and play therapy for method that I using in a consultations. All right. So first step I using I do a consultation with them until I until what what my client told to me and so on. So because actually as a counselor we cannot diagnose our client, right? We cannot diagnose our client. We have our limits, all right? So for the next step, after I make almost 2 sessions with my client, so I refer my client to I refer our client my client to the hospital to meet a psychiatrist to be a diagnosed uh, that he have OCD and so on. So after he meet the psychiatrist at the hospital, he was diagnosed as a OCD, and the psychiatrist was give him a medicine to help them to overcome the OCD and so on. Right, Tommy?
Okay,
All right.
thanks for your experience on this.
Yeah.
So, our principal consultant psychologist, Dr. Edward, have already joined this webinar. So, hello, Doctor.
Hi, how's it going?
Yeah, just now,
Yeah.
Johan is sharing his experience in treating patients with OCD.
All right.
Fantastic, fantastic. Yeah, so this is on the rise, obsessive compulsive disorder, since the pandemic as well as a number of other related mental health disorders, right? And so have you described some of the symptoms
Yeah,
about OCD?
Johan just now already shared about the symptoms of
okay.
OCDs and what is
Fantastic,
obsessive, what does
fantastic,
compulsion mean.
fantastic. Great. That's good. So we can maybe later we can talk a little bit about some of the treatment and some of the underlying causes, right? I'm not sure whether you have a chance to talk about the external versus internal assurance. Have you?
No, haven't.
Not yet.
Maybe
Because
doctor,
with
you can
OCD, say for example, not sure whether I have washed my hand good enough or whether there's still like virus, COVID virus on my hand, right? So I can like ask you, do you think I have a COVID virus on my hand? And you can say no. So that would be an external verification, right? But then I can also do it internally and ask myself, I wonder whether there's still the COVID virus on my hand or not, right? And then that will be internal, right? So there's this two type of verification. Do you talk about that?
Haven't thought about that.
So that's an important aspect, right? Because with the OCD patient, they will need a lot of assurances. So that may ask family members, ask the therapist whether there are still virus on my hand or whatnot, and if you say no, that there's none, right? Then that might reinforce the OCD. You know why? Why would that reinforce the OCD?
It's like keep on repeating asking, because after you ask, then you will want to reconfirm it, so you will ask again, and then this will definitely make the OCD become more serious lah.
So do you know why it will? Yeah, do you know why it will? If you give them that assurance and say yes, there are no virus, that will reinforce the OCD.
Yeah, I think it's because if you are asking, if you're asking for reassurance, right, and then other people assure you, then after that, you will have a thought that you'll want to get another confirmation. Then this will make you to try to ask for another confirmation. So this will make the cycle become keep on repeating the same thing, make the OCD become more serious.
Yeah, so they become reliant on you, right? Reliant on others. Then they never get to be able to deal with their own anxiety, right? And same thing with internal as well, right? So they get caught in this endless negative loop, right? So there's something to bear in mind. So then what is the thing to do then when the patient asks you, right? Do you think that there are virus left, and do I wash enough or not? What would be the therapeutic response to that? Any idea?
So if the patient asking for reassurance from me, then I will tell the patients that no need to worry about this, about the jams, all of these things. You just continue to live your life. So maybe this is like a bit of assurance, but definitely it will make the clients at least won't feel so anxious.
Yeah, so what would be your response if the patient asks you, right?
So definitely I won't give him any reassurance like telling them it's fine, something like that. So because if giving reassurance, then this will only make the cycle of the OCD continue. So what I can do is I will tell the clients to think in a way that he can live with the condition, live with the germs, because germ is everywhere, so no need to worry about it. We just continue to live your life, something like that.
Well, yeah, that can be said once, right? But the issue here is the patient will keep on asking you again and again and again, right? So what would your response the second time around when he asks you?
My response is it's fine.
Sorry.
It's fine, something like that.
Well, problem with saying it's fine is you are reassuring him. Then he'll ask you again next time. Is it fine? He's still relying on you, right?
Okay.
So a more therapeutic response would be to tell him, we already discussed that previously. All right, just let him deal with that.
Mm.
We have already discussed that, and that was good enough, right? So do that. So family members, friends, colleagues, that is the way that you should therapeutically respond to your colleagues, friends, family members who have OCD, because they will keep on asking you for reassurance, right? And internally as well. So the other thing that we can talk about is the neurobiology aspect. But before that, have you talked about schema?
I haven't.
Right. So maybe because OCD is pretty much linked to schema, right? And modes as well. So maybe you can explain a little bit what are schemas and modes for those who are new to psychology and psychotherapy.
Okay. So schema is like a deep program in our mind that developed when we were still in our childhood. So schema is like a thinking patterns that we have. It's like an automatic thoughts that automatic thinking patterns that already developed when we are still young, and then these schemas will still stay with us even though we already grow up, become an adult. So the impact of a schema is it will influence our behavior subconsciously, and then yeah, a lot of the schemas is actually useful when we are still in a childhood, but when we already grow up, the schemas will create a lot of problem to our life. So so one of the things that about schema is, for example, we have one schema known as a vulnerability to harm. So this vulnerability to harm schemas means that you will have a exaggerated fear of imminent catastrophe will happens in the future. So the fear may revolve around things. For example, fear related to medical catastrophe such as heart attack, cancer, or emotional catastrophe, for example, losing it or going crazy. External catastrophe, for example, earthquake or bridge collapse will happen. So people with this vulnerability to harm schema, they will have a lot of negative predictions about the future. They will always anxious and fear that something bad will happen. And this will make them have a behavior, or what we know as a modes. So the modes that are related to this vulnerability to harm schemas might be avoidant protector. So modes is a behavior that are triggered by our schemas. So if we have these schemas, which is like a thinking patterns in our mind, then it will trigger us to react, which is using a certain behaviors to deal with these schemas. So if we have a vulnerability to harm schemas, then definitely it will causes us to have this avoidant protector behavior.
Fantastic, Tommy. So if you have like the schema card, you can briefly show the audience. Yes, so this is a schema, all right? Vulnerability to harm. All right, so the thing with schema is these are your psychological program, like Tommy explained, and we cannot see them as such, right? But what we can see is the behavior, all right? So Tommy mentioned the avoidance protective behavior. Can you show the avoidance behavior protector mode card, right? It's also known as mode. So an OCD, the patient will have this avoidance behavior. So how do we understand that? What are they avoiding? That is a question.
I think they are avoiding the negative or negative things that they predict will happen in the future. They are trying to avoid those things so they won't get into troubles.
Well, I mean, you already like mentioned, you know, germs are good and all that, right?
Yeah.
So so that's not an issue, right? So what they are avoiding is not the situation itself, but the fear of the situation. It's the emotion that they're avoiding, that they cannot tolerate, right? So most likely, you know, COVID is not going to kill them, but it's the fear of the COVID that they're avoiding, right? So that is the emotion. So when you want to like explain the situation to these patients, there is factual explanation and emotional explanation, right? Factual is like what you have done just now, but that normally is not an issue, right? OCD is irrational, right? It's not that they don't understand the facts; they can know all the facts, but they still have this irrational fear, right? So you need to give emotional explanation rather than just a factual explanation, right? Because that's not going to cut it. Yeah. So that is the avoidance part. All right. So how do we deal with that? The avoidance behavior. How do you treat? So you're talking about treatment now. Now that we have some understanding of the formulation, right, of OCD.
Okay. So I think one of the ways for us to treat is we can tell the patients to gradually face the problems that they are avoiding. So this is known as like a gradual exposure therapy. Exposure therapy expose the clients to the things that they are avoiding step by step so that in the future they won't avoid these things.
Yeah. So that using a metaphor will be good, right? In this situation, it would be easier for them to understand. So a good metaphor might be putting your hand or your body, immersing it in cold water, right? Which I do every day to bring down my inflammation. I don't know, you know, you can try it. You know, a bucket full of ice. So at first, when you do that, you know, it will be very difficult. You will like you can't even stand it for a few seconds. But after a while, you know, you do it now. I can do it like for 8 minutes, maybe even longer. You know, no problem, right? So that I can play tennis every day without pain, right? So that is a good metaphor. So once they increase the tolerance of this fear, then they can tolerate it better. They develop this tolerance muscles of fear, right? So this is what we need to work on, increasing the patient's tolerance of the fear. Yeah, and so you're right, confronting it, you know, maybe on a stepwise basis is you know, is a good strategy, you know, bit by bit. Okay, so hope that will give us some strategy on treatment, basically behavioral therapy, right? But with an understanding of the behavior and even of the schema, right? And of course, we can modify the schema, you know, reformat the schema, update the schema, right? Update the psychological program, because all these programs were formed when they were young, right? So we can go back in time, right? do a time travel, you know, and then change it, right? So there are some childhood needs that were not met, like emotional safety. You know, we are not like blaming their parents, but you know, for some reason they did not feel safe, right? So we can go back and help them to give them the necessary reparenting for them to feel safe again, right? So if that is clear, maybe we can talk a little bit about the neurobiology causes of OCD, right?
Yep.
And
So
yeah,
definitely neurobiological causes is one of the things that will make you have an OCD lah. So doctor, what kind of neurobiological things that you're mentioning?
well, there are two things, right? Two type of system: the neurotransmitter system, which is the chemicals in our brain, and also the hormonal system, like stress hormone. You know, when you're having anxiety and OCD, you are under a lot of stress, right? It's just like you are seeing tiger every day. I mean, not even every day, like all the time, right? I mean, if you see tiger once in a while, it's okay. But if you're seeing all the time, you're going to like get exhausted. So it is like that is what is going on for the OCD patients, right? So maybe we can talk a little bit about the neurotransmitter first, right? So we have a neurotransmitter. We have various neurotransmitters in our brain, and later you can share the neurotransmitter sample report. You know, at IPC we do measurements, all right? Because we make use of Well Lab, one of the premier laboratory in you know, in our region, to really measure the different neurotransmitters in our brain. So we have inhibitory, which means like calming neurotransmitters, and excitatory neurotransmitters, those that give us energy, right? So normally in OCD, what you have is too much excitatory and not enough inhibitory neurotransmitters. Yeah, so not enough like inhibitory neurotransmitters would be like GABA, serotonin, you know, and that's why psychiatrists, which we do have in IPC as well, will offer various medication to increase the serotonin and GABA, you know, availability, and to decrease the, you know, glutamine, dopamine, you know, adrenaline type of neurotransmitters, right? But we have, but this is more than just deficiency of some inhibitory neurotransmitters and too much of the excitatory neurotransmitters. You know, it might be more complex than that, because neurotransmitters have receptors, right? So if you say you don't have enough GABA, you know, the question is why, right? It can be because, or serotonin, you know, it can be because of the precursors, right? It's not enough. So this is what we call relative nutritional deficiency. So the question is, why is it not enough? You know, maybe you're not maybe you're already eating enough food for that neurotransmitter, but still not enough, right? So that could be because of some enzyme converting that neurotransmitters is not working properly. So that's one thing. The other thing is the neurotransmitter, say serotonin, right? So say the precursor is enough, but the serotonin is still not enough, right? So that could be then due to maybe the conversion from the precursor to serotonin. It's not working properly, you know, it cannot be absorbed, you know, or the receptors is not working properly, the serotonin is, so it cannot take in the, you know, the signal, right? Or on the other hand, it could be further downstream, right? Because neurotransmitters get broken down, and it could be the enzymes, say COM or MAO, you know, it's working too much, so it all flowed out, just like you have a bathtub, the hole, is too large. So there are a number of these possibilities. So it's not just a simple case of not enough serotonin, right? But it could be different ways that can be manifested. So if you want to show, that's why we need to do a very precise neurotransmitter test. This is a simple urine test, and Tommy, you can show the like a sample report of this test so that audience can understand, right? Why we recommend this test, right? So there's this test here. All right. So in this case, you can see that tryptophan, which is the precursor of serotonin, is in fact enough, right? But serotonin is too low. So then we understand in this case, it is not because the precursor is not enough, right? It's the conversion factor, the cofactors, maybe vitamin B6, which is needed to convert, is not enough, maybe blocked. So there's a genetic condition for methylation, whereby the cofactors can be blocked, right? We can check on that, right? And on the so glutamate here is like too high, right? So making the patient too anxious. Dopamine is also too high, we can see that, making the patient too anxious, right? So we see all these features. GABA is too low, right? So and then the patient will also be anxious. This is a calming neurotransmitter, we can increase that. And go further down, what else can we see? All right, we can see that HVA is too high, right? So that is like the downstream, right, of dopamine. So that therefore we need to facilitate all these neurotransmitter, right? So this is a quick tour of what we are talking about in neurotransmitters, why it's important to do a lab test so that we can customize the treatment on the neurobiological parts. And then on the other hand, we also have hormones, right? So Tommy, if you can share the hormone screen, right? So with hormone, we have cortisol, stress hormone, right? So this is a good one to look at cortisol. And here this is a saliva test on a different time, of the patient, like when they wake up, every half an hour. So it's too high already. See that the patient is under stress all the time, or too high throughout the day, in fact, right? And when it's like too high, right, in the early morning, nighttime, then they cannot even sleep, right? So then we can treat, bring down the cortisol. There are a number of herbs that can bring down cortisol, for example. Otherwise, that they will have eventually have adrenal fatigue, right? There will not be enough cortisol for this patient. Okay, so this is the physical contribution, right, to the patient with OCD and other anxiety issues. That makes sense?
Yep, it makes sense to me, doctor. So all of
Right.
these biological, for example, neurotransmitter, the hormones, all of this is related and might causes us to have OCD if it have imbalances.
Well, yeah, I mean it's all contributing to the symptoms, right? So if you like, you can look at it as a hardware software issue, right? So there are the Schema program, which is the software, the psychology part, but there's also the neurobiological hardware parts, right? That can contribute to it, right? We have methylation, for example, genetic component. I mean, there's no OCD gene per se, but there are a number of vulnerabilities that can contribute to this condition, right? Well, I wonder whether there are any questions from anybody. I can see that there are that number of people in the in our group, or you have guys any other questions that you want to ask about this very common condition now, right? That is increasing and keep on increasing as the pandemic is not going to be over anytime soon. More and more new variants are coming up, more and more infectious, more and more frightening.
Yeah.
The perfect storm for OCD patients.
Yeah, I think so. And it will also causes a lot of anxiety disorder to appear. So if all of
Yes.
you have any questions, you can open your mind to ask. So don't be hesitate because Dr. Edward can definitely help you to answer all these questions.
I have two questions.
Okay.
Yes.
Yeah.
Hi, hello, Dr. Edward. Sorry, it's you me again. I have a lot of questions.
Please, you may.
So
Go do it. Yeah.
two questions. My first question is we've been talking about a lot of OCD symptoms that
Yeah.
I felt it's more like the behavior, like it's a lot of like the like it's all about like cleanliness or like it's all behavioral repetitive
Well,
patterns.
but also avoidance. Like recently, Tommy and I we were working with a patient, and he's just avoiding dealing with his financial situation, right? He needs to like look at his finance, sort things out, but he is like so avoiding of the pain, like that he might not be in a good financial standing, that he's just putting it off, and getting caught in this negative loop, right? So there are behavior that you can see, but there's also behavior that you cannot see, right?
Right. So in that sense, that's more towards like cognitive. Like, can I? Is there like, let's say, there's no OCD. This person has no OCD symptoms in terms of like repetitive behavior. For
Well,
example, like washing
so
hands, but like the more like mindset. Let's say this person will think about the same things like 10 times a day and keep on having like a checklist. So it's more like in their mind. Would that consider OCD as well?
yeah, I mean, OCD is both there's an obsessive part and a compulsion part. So if there's no behavioral part, then you just have the obsession, the intrusive thoughts part, right? So that is not strict OCD, right? But there's still gonna be a disorder, right? An obsession disorder. Okay.
Right. Okay.
So hopefully that answer your question. Yes.
Yeah. There's a question in the chat from Kamini. She would like to know how long does it take to see an effective improvement in OCD patients once they started attending therapy?
Well, it depends on this different intervention that we are able to treat, right? If we can treat the physical part together with the psychological part, then that would be, the prognosis will be faster, right? But if not, then it will be slower. So it depends on that. It depends on how many schema there are, right? If there are like multiple schema, vulnerability to harm, and you also have like mistrust, abuse schema, effectiveness schema, that can be multiple schema at work. Then we need to like restrict each one of these. That would take a bit longer. Right? So it depends on all these factors, and also how long the condition has been. If you've been like having it for years, then the pathway in your brain is very thick, right? To lay new wiring, right, will take time. You know, the alternative highway, you know, that will take time because the old highway is already very established, right? To have new pattern of behavior will take longer. So if it's just a recent, you know, the manifestation, then that will be faster. It depends on all this situation. Hopefully that answer your question, Kamini.
Hello, doctor. Yes, you did. Thank you very much.
No worries, Kamini.
Okay, so doctor, there are further questions. What are the best therapy approach for OCD apart from schema therapy and cognitive behavioral therapy?
Well, like schema therapy, for example, we can use a number of other therapy that is linked to it, that make use of schema, right? Like expressive therapy, art therapy, right? So all these we can look at the schema, right? And then combine it with like Gestalt, right? Working with parts of the patients. We can use hypnotherapy, right? To do the to give a condition like cognitive hypnotherapy to give a new condition, new way of thinking for the patient, you know, for them to really connect with the reality, right? To really get to know a new or alternative reality, right? I mean, all this is part of confrontation, you know, to against the avoidance behavior mode, right? So instead of getting them to actually confront the behavior, we can use hypnotherapy, cognitive hypnotherapy to help them do that, right? So this is quite versatile, and of course, emotion focused therapy, you know, would be also useful to help them deal with the fearful emotion and confront that, right? So yeah, hopefully that answered that question.
Yep, I think it answers many questions. Okay, so any further questions to Dr. Edward?
I have one more question. Sorry.
Right. And who is this from?
Yumi.
Yumi. Okay.
Yeah. The underlying causes. I'm not sure if I catched it. What is the underlying causes again?
Well, there are two parts of the underlying causes, right? There's the psychological one, the schema, right? And there are the physical one, right? Which will be the neurotransmitters and hormones, right? So the both of these can give rise to anxiety, you know, make one vulnerable towards anxiety, as well as the schema. So this is two parts, you know, in terms of the underlying causes.
Right. Okay. Thank you, doctor.
No worries.
Okay. Any further questions?
I have question.
Oh, Siti, right?
Siti, yeah.
Okay.
I would like to know if children can have OCD too.
Definitely.
What's the cause of their OCD?
Well, again similar, right? So the like I think you know, yesterday case study we dealt with you know, a very severe situation of the child having cancer, you know, needing an amputation, parents getting divorced. So all these are external situation. If they are not like communicated, you know, convey in a way that is helping the child to mitigate their feeling of emotional safety, then that can indeed cause OCD and yearly ask, can trauma, yeah, big time trauma, emotional trauma, physical trauma, all this can cause OCD in children. But of course, at the same time, the physical elements is also can contribute, right? The child have neurotransmitters, have hormones as well, and if there are imbalances, that this can make them more vulnerable. So quite similar, right? And all the more reason with children that we do not recommend the heavy psychotropic psychiatric drugs, because of all the side effects. Rather, if this is a physical contribution, then we will recommend the safer, more natural nutritional medicine, right? For if there are physical underlying causes. So we need to do a proper case formulation to identify whether there are one or both of these underlying causes, physical or psychological or both.
Thank you, Doctor.
No worries. But if OCD in children are not treated, then it will continue to haunt them as adults. So it's important we help children, as well. So the question on trauma, one trauma can lead to other trauma. So you can have like a network of traumas, right? But we want to trace back to the earliest trauma. And once we rescript them, they'll be easier for us then to process the other traumas.
Yep, it makes sense, doctor. So we need to deal with all this trauma. So to use a therapy to help the patients, especially those children that have OCD. If not treated, then this issue will still continue when they are in adulthood. Okay.
Indeed.
So,
yes, and that would be more difficult to process.
Be difficult to process because, like what you say, the highway is already established. So to on a new one would be very difficult.
We already have a super highway.
Yeah.
All right.
All right. So, any further question to doctor regarding this OCD?
May I say something? It's not a question, but can I comment about something?
Can.
Yeah, sure.
Yeah. Regarding OCD, right? Just now we talked about one is behavioral, one is cognitive, and for behavioral, like if you have OCD, I guess self-awareness is like easy, like it's easy to identify behavioral, but a lot of people, I felt that like if you have OCD, like cognitive, like psychologically, most people don't realize that they have that and they can't identify. Maybe lack of knowledge, or like they are not actually aware that they have OCD symptoms. So it's very hard to treat unless you're like very self-aware, very well exposed.
Yeah, I'm not sure about that. I think with OCD patient, they are aware that they have this dysfunctional thinking, right? They very often that they will report to you like like we have a patient that have this thinking that he's looking at the breast of a woman, right? And even though he might not be, but he has this thinking that he is. So it's really disturbed him, right? So he is fully aware that of this cognitive problem, right? So yeah, so I think very often patients can be aware of their intrusive thoughts, because it's very intrusive, right? Even though they don't want to think of it, it's keep on occurring. Yeah,
Right.
so that's
yeah. How do you, excuse me, how do you, can you hear me?
Yes.
Hello. Yeah, how do you deal with an adult? I think he may not be aware that he has this problem. And even if you should bring this up as a suggested problem, he denies it. He doesn't see anything wrong with him, but he is obviously very, very anxious, overly anxious. And we say you fear this, you fear that. He will not say it's fear. It is taking precaution, extra precaution, but everything is so dirty, and so everything is virus, everything is COVID, everything is it's so stifling to be in such an environment. Well,
Yes.
is this OCD?
Yes, it is.
It
It
is,
is. When it becomes stifling
Obsessive.
and
To me, it's
dysfunction-
obsessive fear.
and dysfunctional.
Dysfunctional. So how do
Anything.
you?
Yeah. So we would first of all we would need to help him to gain the insights. All right. So the first step in treatment is for the patient to admit, to acknowledge that they need help. So if he doesn't have that insight, then this is the first thing we need to work with him on. All right. It's not like normal to like spend so long bathing or washing, right? So and maybe we can compare with other people. Yeah, so that it would be the first step to break in, to get a buy-in. Okay, but Tommy, I think our time is up. We have another patient. So
time flies.
Yes, time flies when you are enjoying. But later, I think you need to cut out all those earlier Starbucks issue that I have.
Okay, no problem. So
Okay.
thank you everyone for joining today's webinar, and thank you.
So if you want to talk more, we have Malay and Chinese webinar on the same topic coming up. All right, so watch this space, and we can talk further. All right.
Yeah. So
but
thank
in
you.
different languages. Okay.
Yep. Thanks everyone for joining. Thank you, Doctor, also for answering
No
all our
worries.
questions. So goodbye, everyone. Have a good day.
Bye bye.
Bye bye.
Bye bye. Bye.